Senator King.
Thank you, Mr. Chairman. First, I want to thank you for having this hearing, very timely and important. Secondly, I want to associate myself with Senator Cotton's comments about a sort of Berry amendment for drugs. The idea that we have to buy made in America shirts for our troops, but we're worried about the availability of crucial drugs. It seems to me that's something that should be pursued. We could even call it the King-Cotton Amendment, but I'll pass on that. Also, Mr. Chairman, before getting into the questions, and these witnesses wouldn't have the answers, but I think in light of this hearing, the committee should make an inquiry about whether there have been firings or early retirements encouraged within the medical facilities at the Defense Department, because we know there's a lot of that going around, and I'd like to know whether that's happening in the Defense Health Agency. Secondly, there's the impact of the continuing resolution. That's certainly not going to help this situation in terms of maintaining demand signals, continuity, pilot programs. All of that is gone in a continuing resolution. For the first time in my knowledge, I think the first time in American history, we're faced with a year-long continuing resolution, which basically vitiates the entire budget process. Okay. What we're really talking about, it seems to me, is surge capacity. And it's impractical to maintain a capacity within the Defense Department or even Defense plus VA for the kind of casualties that would be generated in a significant conflict. Therefore, I see no other alternative than a cooperative surge agreement with the private sector. That's where that's where capacity is, even though that's fairly limited. But Dr. Friedrichs, isn't that really what we're talking about here? Is how do we deal with a conflict way beyond what we're seeing now within the current capacity? Defense Health Agency couldn't do it. VA couldn't do it. It's got to be it's got to be relationships, and shouldn't we have those relationships in advance so this isn't something that we scramble to do as we did during COVID, for example?
Senator King, I could not agree more strongly, and I'll point out that.
Show that what he
thank you, sir. So, in the Cold War, we had what was called the Integrated CONUS Medical Operation Plan, which it was essentially what you just described. It was our shared commitment as a nation to care for our nation's casualties if and when our nation went to war. That depended on the National Disaster Medical System as part of the integrating function between the federal and the civilian healthcare system. The NDMS has been allowed to attrit. I echo the recommendations to reauthorize the Pandemic and All Hazards Preparedness Act because that, in part, enables the NDMS. But I implore you to go further. The Integrated CONUS Medical Operation Plan needs to be updated, and we started that work when I was the Joint Staff Surgeon, and it's continuing today. Having the NDMS in name is not sufficient. We actually have to build out the numbers by community of what beds would be available, who would take them.
With pre-existing conditions and analysis of needs.
Yes.
And I just wonder if the Pentagon has war gamed this issue.
They did while I was the Joint. Absolutely, sir. We actually did a war game on this that we hosted first when I was the Transportation Command Surgeon and again when I was the Joint Staff Surgeon. And what we found was, just as you said, it can't be done unless it's a whole-of-a-nation effort. And the only way to get to that point is if we do much more detailed planning. Taking down funding for state and local readiness officials, for example, is not going to help them do more planning or preparing. We need to work together to build and flesh out that plan, and we must bring industry into that. The defense industrial base provides the equipment. The health industrial base addresses the points that you made.
And we have an analog in Transcom, which has agreements with the private sector, both in terms of airplanes and ships, in the case of an emergency. That's where our surge capacity is. So it seems to me, I mean, here we are talking about it, but I think there needs to be some very specific good new looks at this relationship in order to be ready. So again, we're not scrambling. Dr. Robb, you're nodding. I take it you agree.
Yes, I would absolutely concur. And again, I keep going back to the same theme: is we've got to build up those 6 to 8 to 10 strategic military treatment facilities. We have to resource them, and then you create the already established civilian military VA partnerships, you know, and then you just keep expanding that ring. But you have to have those relationships codified and in place, and that's what Dr. Friedrichs is talking about. You can't just all of a sudden, when it kicks off, pick up the phone and say, how's it going?
You got to have them in place before the crisis hits.
Absolutely.
Thank you, gentlemen. Appreciate it. Thank you, Mr. Chairman.